My name is Anafi Mataka, and I will be your host today. Today we have lined up an interesting topic in the form of generating demand for viral load testing. Why did we think of doing that this month? This is one of the key elements that we have all noticed, I think, for the past couple of years. Demand creation has been one of the key areas that has been prioritized as far back as the Uganda meeting, for those that were there during the face-to-face meeting. And that theme continued to go on for subsequent years through also last year, and currently is still a key area that we need to keep on strengthening. We are doing so because despite the scale up of testing and all the innovations in diagnosis, treatment, and prevention, we realize we still are not meeting the global targets. Many countries could not meet the 90-90-90 targets, and we are still looking at how we can be best positioned to meet the 95-95-95 targets. And global guidance has been produced where we are all advocating for effective demand creation, targeting those people that may be uninformed of the need for testing to actually be able to use this. This stretches more up to elements such as utilizing the diagnostics themselves for us to be able to even better negotiate for better prices. You have heard of that. So it's a wide topic that touches many of us. So today we will be looking at some of the efforts that have been done by our partner, ITPC, and fellow countries late last year in terms of generating demand. I would not want to preempt much of what they are going to say, but this will be an hour-long session. We hope we can add a little 5 more minutes to cater for the logistics delay that we had. We will start with presentations, followed by a question and answer segment. Please keep your questions and comments coming through into the chat box as we go through. Of note is that we have simultaneous language interpretation, French to English and English to French. Specifically for today, we advise you to switch on to the language of your choice. Either choose English or French, and make sure you mute original audio when the French version comes, so that we are all will all be able to hear the interpreter as the presentation in French will be ongoing. Without taking much time, I would like to call upon our first presenter, who is from the International Treatment Prepared Coalition, ITPC, and her name is Ponso Pilane, who is a communications consultant, to take us through the introductory remarks, and then we will lead into the country presentations. Ponso, over to you.
Thank you so much, Anafi, for the introduction, and good afternoon, everyone. It's so lovely to be back here again in one of these meetings. It was exciting to be here the first time. So today, I will just be introducing the campaign and how these community-led campaigns can work towards increasing tests and increasing awareness. As Anafi said, I am with ITPC, where I help with communications. So without further ado, I think where we should start is in understanding the objectives of the campaign and why the campaign was started to begin with. So we wanted to develop a tailor-made communications campaigns for each of the 6 countries where we were implementing this routine viral load campaign. And this was to mainly raise awareness and to create demand for routine viral load testing in these countries. And so Another key factor of this campaign was that it needed to be community-led. So it was not a top-down effect, but more of a bottom-up, where the communities and the people and the organizations that live in these countries and understand the cultural, the normative ways of life in those countries we basically take the lead from them around what an effective communications campaign looks like. Another objective was also that in the combination of the community organizations as well as the lab officers and Ministry of Health representatives, that we train these country LabCoP teams into understanding the importance of communications campaigns, how they work, and how we work together and collaborate in creating this communication campaign, particularly for routine viral load countries. And these six countries that we did this with was the DRC, Kenya, Malawi, Sierra Leone, South Sudan, and Zimbabwe. And this campaign, the first leg of this campaign ran from October last year until January 2021. And like again, during the early stages of the campaign, before the campaign actually ran, there's a lot of background work that was being done around preparing the teams, ensuring that our key messages and even the materials that we are preparing, as well as who the campaign is targeting, was clearly thought out, and it was ready by the time everything was ready when implementation started in October. So each of the country plans, the communication country plans, as we said, that each country had its own communication plan that was specific to the needs, the situation, and the target groups that were chosen by each country team. And this was so that the campaigns could reflect or could resonate in the communities in which they will be exposed. And so the country plans were first, we started really by identifying the main issues. And as you'll hear, as my colleagues from the different countries talk, they will share on what these issues were in their respective countries. We also looked at prioritizing, targeting certain populations. And this was also dependent on the vast knowledge from the country teams and the organizations who were working on the ground on who would be best suited, which populations would be best suited for this for the communication plan. We also really worked through and discussed in great detail which media platforms would yield the most results, but would also be perfect for this campaign. And in this, as you'll hear from the different country teams, this was an interesting part and was a very instrumental part in the campaign, particularly thinking that when we think that our campaigns were mostly rooted within digital media platforms. And so knowing the digital divide that is there within the continent and in different countries in particular, deciding on media platforms was a very integral and important step in the program, in putting together the communication plan. We'll also develop the key messaging so that for each priority target population, we have messaging that resonates with the problems that these target populations experience in the different countries. And lastly, in order for us to see whether or not this campaign would be successful, we had to work out a tracking and outcome indicator and a monitoring and evaluation tool that allows us to be able to see the progress of the country plans and the implementation process, and also the things that we can improve during the implementation as well as at a later stage. And at this stage, the outputs were a communication plan that was specific to each country group. So there were in total 6 communication plans. And at first there was one indicator tracking sheet. However, they were tweaked. The tracking sheets were tweaked for each and every country team so that it was easy and it was adapted to the priority target populations, the media platforms. Particularly, those were the 2 issues that we needed to make sure we're able to monitor and evaluate with the indicator tracking sheet. And lastly, when the communication plan was done and before we implemented, we had the messages, we had flyers, we had various multimedia material that was created around campaigning for routine viral load testing that each country team used, and we will see these as my colleagues present. And this is just an overall, this is just a summary of some of the successes or the results of the various implementation phases in the various teams. And I'll start just briefly going, overviewing each of them. As I said, and as Anafi has said, that the country teams will go into specific details. As I said in the previous slide, that each team, each country team chose specific audiences, or rather target populations. We had men living with HIV, women living with HIV, pregnant and breastfeeding women, as well as young people and adolescents. Key populations such as men who have sex with men and sex workers, healthcare personnel, religious leaders, as well as the departments or the ministries of health as target audiences. And various platforms were used by the country teams. There were some overlaps in terms of platforms, but there were also very interesting and unique platforms that were used, such as bulk SMSs, the use of peer educators, using obviously social media platforms like WhatsApp, which is the most popular on the continent, and it's not a surprise, as well as Facebook, Twitter. Radio was also used, as well as support groups. And what is interesting about the platforms is that even though the campaign was mostly, or rather geared to be a digital campaign, because of the different unique situations each country teams found themselves to be operating in, whether it was, as you'll hear later on, in terms of the fact that we are reaching a group of people who are not on social media, or where a social media platform would not be suitable for them, and so forth and so forth. And we'll hear details from my colleagues as they give their presentations. But some of the greatest reach in terms of audiences that we experienced was with women, with young people, with women living with HIV and expected mothers, and different countries reach different audiences. As you can see there, the DRC, it was women, and with Kenya, it was the youth. With Malawi, it was women living with HIV and expectant mothers. And for specific reasons that you'll hear from our colleagues from Sierra Leone, their reach was, it was quite different, and it is quite an interesting way in which their campaign had to turn out, which still yielded results, even though it wasn't the results that we had expected. And in South Sudan, youth were the greatest reach through radio, and in Zimbabwe, adult people living with HIV was the greatest reach, again with radio, again, the point I said around, even though this was a digital campaign, depending on the different situations in the countries, we used non-digital platforms such as radio. And just moving along with regards to this, there were lots of lessons that we learned through this campaign. Particularly one is that when you're rolling out a campaign, and particularly when you are looking to raise awareness on routine viral load testing, or something that is not necessarily well known, we need sufficient time to communicate and reinforce messages. So one lesson that we learned is that the implementation time between October and January this year was short, and that the message was not necessarily re-emphasized enough. Another key lesson, we all know that we are living through a global pandemic, and the regulations and restrictions that were happening in the different countries at different times also hampered the effective implementation of the campaigns. And our colleagues from Zimbabwe will talk more about how this impacted them. And also realizing that effectively using digital and non-digital methods is the key, particularly when you're looking at a continent like ours and the countries that we have chosen. There is a massive digital divide. However, it is also knowing and being cognizant of the fact that data costs are high, as well as technology technological barriers where people don't necessarily know how to use these platforms. So for example, we saw that social media platforms were effective, but they had limitations in terms of reaching certain subpopulation groups, such as adult people or elderly people within rural areas who have limited literacy, or who cannot use phones or don't have smartphones to be able to go on Facebook, on Twitter, on LinkedIn and Instagram and so forth. We also realized that all the country teams had peer educators and in-person meetings to reinforce the messaging, and answering queries as well as correcting misunderstanding was very, very effective. And so the combination of digital and non-digital methods in the campaign strategy was a very key factor in success. And it shows that with the limitations that I've mentioned around literacy, digital literacy, rural areas, and also in infrastructure and systemic issues around digital technology that are beyond everyone's control, this hybrid model works better. And lastly, the campaigns were also on one side of the coin, and by that we mean that there were other systemic issues that needed to be addressed, such as the lack of reagents in the DRC, or a non-functional viral load machine in Sierra Leone. And so what we learned from this is that even though you can plan a communications campaign to implement it in a certain way, there can be things that stand in the way. And I'll leave it at that so that my colleagues can go into more granular details about some of the interesting findings and experiences they had as they were implementing. Thank you.
Thank you, Ponso, for the comprehensive overview of what happened within the countries. So moving on, I would like to call upon our first presenter who's going to give us country experiences. And let me call Gloria Moses from the National Empowerment Network of People Living with HIV and AIDS in Kenya, popularly known as NEFAC. Gloria, please share your slides and take us through. Colleagues, keep your questions and comments coming through into the chat box, and we will take them at the end of the presentations. Over to you, Gloria.
Thank you, Anafi. So I am sharing my screen. Just let me know when you see it. Are you able to see it? Hello, are you able to see my slides?
Yes,
we're able to see.
All right, thank you so much. Hello, everyone. As introduced, my name is Gloria Kerubo, and I work with the National Empowerment of People Living with HIV and AIDS in Kenya. In the start of my presentation, I'd like to introduce our implementing partners. So the lead organization, Big Network, which works to unite people with HIV and those affected by HIV and TB, through community-based organizations and support groups. Our second implementing partner will be IREP, which works with and for adolescents and young people with HIV and giving information on SRHR. Our third partner will be Positive Young Women Voices, which works with women in all diversity and mostly in slum areas. So that will be the informal settlements. And then last but not least, we have the International Community of Women with HIV in Kenya, which basically works with women living with HIV. So for us, the period of the campaign, we did it for 3 months, and then the last month was for reporting. And as you can see, what we did, so through the slides, you will see a bit of pictures. Most of them will be some of the infographics that we use the campaign. For the period of the campaign, we did it for a period of 3 months. And what we did is we aligned most of our activities to match with existing events. So for example, we had Twitter chats, we did them on World AIDS Day. Then how do we relate VL with World AIDS Day and UHC? Then for universal health coverage, how do we relate viral load testing that is routine with universal health coverage? And then how do we bring out viral load testing as part of the human rights in terms of accessing accessing quality medical services from healthcare facilities. For our planned activities, try to be dynamic, so to include both social media and physical meetings and radio campaigns. So for social media, we were basically targeting to use Twitter and Facebook, but during special occasions, we realized that we had to switch and include WhatsApp and so for Twitter chats, basically for awareness and demand for investments to be made. So once you do demand creation, once the recipients of care are able to demand for these services, then we're demanding that government invest in such services. So when you want to seek viral load testing, when should be able to access them? For our campaign, we decided to use hashtag why viral load matters. Why we decided to use this because we thought this will be a way for us to educate people on why do you need this, because we realize that most people don't have information, and when they have information, it's not as comprehensive. So why viral load matters to PLHIVs. And as Alfonso had mentioned, we influencers for greater impact. So what we usually trained a group of people from the community who will use as our key speakers and representative and champions for the VL. Able to go, and when we're doing Twitter chats, they are part of the campaigns, and they have, of course, on social media platforms. For Facebook Live, what we did, so we decided to do a bit different for Facebook. We decided that Facebook will be for experience sharing. So for our populations, the most population that we focused with was adolescents and young people and women, especially breastfeeding mothers and young women. So we will do a panel on Facebook Live. So we have people who are living with HIV, as part of the panel, giving information on how VL, the experiences with VL, have they accessed such services, how was it like, and what time it took for them to get their results back. So we did one training, and what we did, as I said earlier, we were doing targeted activities, and this we conducted during a young people's meeting, and as you can see, it's mostly young women. And for us, so it was part of the DSD model. So for us, what we wanted to do is to give the young women information on, VL, and then giving them the power for them to know that they are able to demand for these services in case they're not getting them. So as you train them and then you encourage them, once they go out there, information with the other community members, and parts of the invite clinicians. So the clinician came the last few minutes for us to talk to them, and they tell them that if young people come to you and they want information on such kind of things like VL, then you're able to provide it to them in a language that they're able to understand. For the radio campaign, it was a local radio, so our target was mostly people in informal settlement, because if you look at the radio station that we used, it speaks in a language that most people in informal settlement use, which is the slang which we call Sheng. And for us, the radio station was just basically share information and give information to the communities, not necessarily targeting PLHIV, but to give to the entire community. So from what we learned, what we think works is that social media works well. If you use Twitter well, it works well. So it gives you good numbers, you get retweets, you get likes, and people get to share information. But then the challenge with that is that you're not able to measure to what extent people have understood this information, which is the advantage of the face-to-face meeting that we had, because you're able then to ask them questions. What have you learned in this meeting, in this training? Is it a sensitization meeting? Then what have you been able to learn? Do you think you've understood? Can you then share this information to others? But then that also comes with a challenge, because we're in the COVID times. And in the COVID times, we have restrictions and guidelines that are put in place to flatten the gap. So you can only meet a few number of people, and for a very short period of time, and within certain areas. There are places that you're not allowed to travel to. The observations that we made is that we still have lack of information on what VL is. some of the recipients of care don't know when and where to access such kind of services, and they don't believe that it's part of what the care package. And then there's a bit of communication gap between the healthcare providers and recipients, and could be as a reason of implementation of guidelines, or it could be because probably the level at which the level of information between the two is, not everyone is on the same level. And then you realize that there's a gap between when one tests for VL and when they get the results back. So it's not consistent. And if you look at during the COVID times, it has become worse because I think health systems are prioritizing COVID tests, meaning that there's a bit of small room for the VL results. The turnaround time is a bit longer. And then despite having guidelines, so actual implementation is not happening of the guidelines that have been set on VL. And then there's a need for treatment literacy for PLHIV, not only on matters of VL, but as you're doing that, then how do you complement the information on, what kind of medication are you on? What do you need to do as a person living with HIV? Such kind of information is a bit missing. And I guess our way forward, so as part to respond to some of the observations that we made, is that there's need to implement further information and awareness and demand more for, and create demand for viral load testing, which is routine. And then there's need to include general treatment literacy. So whether it's at facility level, but mostly at community level, and where we are asking for investments to be made at community level. So we, as communities, we are able to pass this information to other communities. So as I learn through VL, then I tell my neighbor, then my neighbor tells my neighbor. So investments at community level to pass this treatment literacy. And then there's need for advocacy. And when you're saying advocacy, then we don't deal with, for example, upcoming issues like COVID. Then we don't deal with COVID in isolation. Then how do we work? How do we include COVID and HIV and not isolate one of them, because they are both important? So what are our planned activities for the phase 2? So for phase 2, we want to increase impact on what we did last time, just to add on what we did before. So what we are going to do a bit different this time around is just to start with a focused group discussion. And this is, so when we're doing the pre-campaign focus group discussion, we are basically asking people, what information would you like to see when we are doing the phase 2? What kind of information do you want? What do you want us to do in the phase 2? So we are able to tailor this campaign to their needs, to the needs of the communities. And then after the campaign is done, we do a post-FGD to gauge where we are. Did we achieve what we set to do? Did we answer all the questions that we were asked before the project started? And then we of course will do social media campaigns, and these will be Twitter chats and Facebook. And then for the social media, we realized that there's a need for WhatsApp, but this will not be as a standalone activity. It's just a supplement, because people needed a place where they can talk to each other. So we formed a WhatsApp group to serve as a WhatsApp group, to serve as a support group, and a virtual support group. So we'll doing that, and we'll continue giving information on the same. And then we'll have Zoom trainings, because we realized, again, after you've done social media, there are people who still have questions that they need answers to. Then having Zoom trainings and webinars then allows us to talk to them and answer their questions. Last but not least, we'll have survey and polls, so to kind of get, what do you think about what we've done so far, so we can do it. And then we get information, so probably what do you want us to do then next? After we've done this, what do you want to see next? And that will be it from me. Thank you so much.
Thank you very much, Gloria, for the wonderful presentation and showing the great work that you have done in Kenya. Colleagues, allow me to quickly switch on to our next presentation, which is coming from Sierra Leone. Mr. Idrissa Songo, who is the Executive Director of the Network of HIV Positives in Sierra Leone, NETIPIS, is going to talk to us on the work that he has done in Sierra Leone. Over to you, sir.
My name is Idrissa Songo. I'm presenting from the Network of HIV Positives in Sierra Leone. As it was stated by Ponto, we actually had challenges, and those challenges led to the fact that we are not able to conduct viral load because the central platform was broken down. In fact, it took almost a year, and so as a result, we were not able to create demand for that services. But despite that, we are able to engage in other activities. Among the activities that we are engaged in was that we convened 3 advocacy meetings with partners. One of the meetings was an extended technical working group, and we also had 2 technical working groups on treatment, in which we actually flagged these issues of the viral load not being functional and how it affects viral load monitoring. We were also able to engage key partners individually in their offices. And so that advocacy led to one of the partners, AIDS Healthcare Foundation, to actually support in the repair of the platform. And also they were able to procure 1 gene expert machine, which was installed at the main referral government hospital. Another partner, actually known as ICA, also supported logistics for the central platform. So in the absence of the central platform, the country was using 3 gene expert machines. But then this was not just for viral load testing, it was also done for EID and also for TB. And so you imagine that viral load uptake was really very, very small. We have, apart from that, we have very key challenges. And one of those, as I've mentioned, has to do with the breakdown of a central platform for viral load testing. Another big challenge was that there was a very rigid service contract for the maintenance of the viral load. In fact, this resulted in delays because AHF had consented to provide resources for the maintenance of the platform. And then the contractors were saying they will not deal with any third party. And then AHF on their part said they cannot give their resources to a third party. They may need to link directly with the service providers. And so this took for over 2 months before it could be resolved. Another issue also has to do with power supply. The CPHRL does not have reliable power supply. So this also is a very big problem. One key challenge also in the country is the fact that we are completely over-dependent on the Global Fund. And so when the Global Fund is not able to respond to an issue of emergency, then it becomes very problematic for us. Now, what are the things that we want to do now that the viral load has been installed? We now want to train peer educators or peer influencers. These are people that we use to actually help to engage our target audience. We are targeting recipients of care. We are targeting key populations. Among these key populations, we will be targeting the sex workers, female sex workers, and men who have sex with men. And we'll also engage in mother mentors. And once that training is done, we'll engage in intensive demand creation so that viral load uptake will be enhanced, and we'll be using various platforms. We'll be using in-person engagement, wherein we engage support groups of recipients of care. We'll be using WhatsApp. Of course, this is very widely used in the country. We'll also be using Facebook. And we will develop radio jingles to actually give information to people about the importance of viral load. And then we will engage in radio discussion programs in which this will be live programs wherein people will have the opportunity to call and ask questions. So in this program, we will not only be targeting recipients of care, but we'll target the broader community. But our focus will be on viral load. And we will continue with our advocacy for sustained viral load monitoring. This will not only be targeting recipients of care, but we will also be targeting service providers so that we avoid the experience we are just coming from. Thank you very much.
Thank you very much, Idrissa, for sharing the Sierra Leone experience. Let's quickly move on to the DRC, and Anke Mavula from the DRC is going to also share with us the experiences that they had from the Democratic Republic of Congo. He is from the UC-COP, a network of HIV positive people in DRC. So Ange, over to you. Ange's original language will be in French. So for most of you that are on the English channel, keep on the English channel, but make sure you mute original audio so that it will not cross over with the interpreter. Thank you. Over to you, Ange.
Merci, bonjour tout le monde. Je m'appelle Ange Mavula. Je suis le secrétaire exécutif de l'Union congolaise des organisations de personnes vivant avec le VIH en République démocratique du Congo. C'est en fait un réseau pays des organisations de personnes vivant avec le VIH. Nous avons participé à la campagne. Nous avons participé à la campagne de la charge virale qui s'est déroulée du 19 octobre 2020 au 19 janvier 2021. Cette campagne en République démocratique du Congo était vraiment inclusive parce que regroupant 3 organisations de lutte contre le sida et bien évidemment sous la coordination du Programme national de lutte contre le sida. C'est pourquoi vous voyez les 3 logos au bas de ma présentation. De cette campagne, ou pendant cette campagne, nous avions ciblé 4 groupes de gens. Le premier groupe, ce sont des personnes vivant avec le VIH adultes. Le deuxième groupe était les femmes enceintes et allaitantes. Et le troisième groupe était celui des jeunes. Enfin, le quatrième groupe ciblait les prestataires des soins. Et dans la répartition des tâches, ICO+ s'est focalisé sur les PVH adultes. Femmes+ s'est focalisé sur les femmes enceintes et allaitantes. Le RACOJ, qui est aussi une association des jeunes, s'est appesanti sur les jeunes. Et bien évidemment, le Programme national de lutte contre le sida s'est appesanti sur les prestataires des soins. Tous ces groupes avaient été sensibilisés à pouvoir avoir avec eux la connaissance sur l'importance de la charge virale. Un accent particulier a été mis sur les prestataires pour que ceux-ci puissent susciter auprès des bénéficiaires cette connaissance de la charge virale, cette information sur la connaissance de la charge virale. Et il leur a été demandé de pouvoir dupliquer l'information auprès de leurs pairs pour que l'information aille comme le système de boule de neige. Vous voyez là-bas, sur l'écran, au-dessus, c'est le message en français qui était adressé aux jeunes. Et le message en bas aussi, là où il y a mon curseur, c'était aussi des messages adressés aux jeunes en français. À gauche, vous voyez, c'est en swahili. C'est le message qui est adressé aux femmes enceintes et allaitantes. Et plus à droite, c'est le message en chiluba pour les personnes vivant avec les VIH adultes. Il faut dire que dans notre pays, nous avons 4 langues nationales, plus le français. Donc, tous ces messages pour tous les groupes étaient traduits en ces 5 langues, c'est-à-dire le français, le lingala, le chuluba, le swahili et le kikongo. Ça, ce sont les plateformes que nous avons pu utiliser. Il y a Facebook, Twitter, LinkedIn, Instagram, YouTube et notre site web. À droite, vous avez tous les liens quant à ce. C'est vrai que nous n'avons pas utilisé l'hashtag connaître ta charge virale. Cette fois-ci, on le fera. Ça, ce sont des résultats par plateforme. Vous avez à gauche les résultats en rapport avec Twitter. Au milieu et à la fin, ça c'est Facebook. Ici, ce sont des résultats d'utilisation de notre site web. Il a été trop visité pendant cette période de la campagne. Ça, c'est encore la synthèse de tweets. Et à droite, c'est LinkedIn. Ça, c'est YouTube. Voilà, pour ce qui est des résultats. En fait, il y a une histoire très importante qui nous a été, que nous avons vécue et que nous avons voulu partager avec vous. En fait, pendant la campagne, il y a une dame qui, depuis 2018, est suivie ou prise en charge à l'hôpital général de référence, chez nous à Kinshasa ici. Mais cette dame n'a entendu parler de la charge virale que pendant la campagne. Imaginez, depuis 2018, jusqu'à entendre parler de la charge virale en 2020. Donc, elle n'a jamais fait la charge virale. Elle ne savait pas c'est quoi la charge virale. Alors, pendant la campagne, ayant entré en contact avec nos messages, la femme est venue nous chercher pour savoir davantage. Et là, quand nous lui avons expliqué, nous lui avons orienté vers un centre de prestation de soins différenciés qui est le PODI. En fait, c'est un poste de distribution d'ARV, mais qui parfois, ou de temps en temps, reçoit les prestataires de soins qui viennent prélever les échantillons pour la charge virale. Et pour la toute première fois, cette femme a fait son examen de la charge virale. C'est vrai que la campagne était déjà passée. 3 semaines plus tard, la femme est revenue nous dire que les résultats de sa charge virale étaient, disons, sa charge virale était supprimée. C'était une bonne chose. Et du coup, cette dame n'a plus voulu retourner à l'hôpital général de référence. Elle a préféré être orientée au PODI pour la suite de ses soins. Et c'est ce que nous avions fait. C'est un bon résultat, un résultat palpable à l'issue de la campagne que nous avons menée. Et pour la suite, c'est vrai que pendant que nous faisions la campagne et que les gens allaient dans des formations sanitaires, il arrivait que ils puissent trouver là-bas, vous retrouver là-bas sans intrants pour le prélèvement, ou que les machines sont en panne. Et parfois, ça décourage. Dans l'avenir, nous pensons qu'il est bon ou qu'il serait bon, en même temps que nous faisons la campagne, en même temps qu'il y ait aussi cette grande campagne de prélèvement des échantillons pour qu'on ait des résultats immédiats et beaucoup plus palpables. La tâche est lourde, c'est vrai, comme vous voyez, cette en fait le VIH. Juste pour dire que la tâche est lourde, mais avec un effort, on pourra arriver. Voilà, encore une fois, merci de votre attention. Le chemin à parcourir reste long, mais il faut partir de quelque part. Je vous remercie.
Thank you very much, Anshe, for the wonderful presentation and sharing from the DRC. We would like to take the last presentation from Zimbabwe, and this will be presented by Mr. Tonderai Mwareka from the Zimbabwe National Network for People Living with HIV, ZNNP+, to take us through. A reminder, if you happen not to get any audio coming through, just go back again and just unmute the original audio. Please, over to you, Mr. Mwareka.
Hi, can you see my screen?
Yes, we can see you.
Okay, thank you very much. And so I'll go through my slides, and I'd like to appreciate this time and opportunity that you have given us to share with you what we have been doing around routine viral load demand creation. So Zimbabwe National Network of People Living with HIV is an advocacy organization that represent the interests of people living with HIV and ensure that their rights are respected. And the organization has got structures at national and sub-national levels in Zimbabwe, and our work focuses on HIV prevention, treatment, care, and support. So most of our work, we create support systems for people living with HIV through the support group model and other models of peer support. Routine viral load demand creation is one of the key issues that ZNNP Plus focus on, including engaging the recipients of care in literacy education around routine viral load testing. For this campaign, ZNNP Plus was the lead agent, and it worked with Zimbabwe Young Positives, which is a network of young people living with HIV in Zimbabwe. And then for this campaign, we also developed some materials, and they were deployed deliberately to the targeted populations. And we also engaged in some feedback sessions to get and understand the impact of what the messages could have had on the targeted populations. Then these are the target groups that we looked at: young people living with HIV, men living with HIV, pregnant women living with HIV, and key populations, specifically sex workers. So the platforms that we used YouTube, WhatsApp, website, Twitter, as well as the radio, and those platforms and the numbers that we reached is indicated. For Twitter, those views, retweets, and likes. YouTube, we had those views as well as WhatsApp. These platforms were based on areas or platforms we thought most of our target population spends most of their time on. And so that's what informed the choice of the platforms that we were used. And of course, one of the weaknesses was that we took some of the things for granted, and some of the target populations couldn't couldn't be part of some of the platforms that we chose in the beginning. So in terms of outcomes of this demand creation activity, it was that it acted as a reminder for routine viral load testing for the recipients of care, and it was empowering to them because most of them never engaged healthcare workers to understand what was the meaning of their result if the healthcare worker does not take that initiative. And with the challenges of the healthcare worker shortages, most people simply ignored their results, and they wouldn't, they didn't have the confidence to engage the healthcare worker and discuss issues around the meaning of their results. So right now, as a result of this, it was reported by the recipients of care that they can now engage service providers and discuss issues around viral load testing. In some instances where the healthcare workers might not have time, there are some peer educators that they can also have time to discuss with on issues to do with viral load results and its meaning as well as interpretation. So these were some of the quotations that were recorded during the interaction on the feedback meetings with the various subpopulation. Like a woman living with HIV said, I managed to assist my peers to access and engage health providers and peer counselors on viral load tests and result interpretation. And then a young person living with HIV said, viral load is important for people living with HIV. What is needed is to get reminders from various stakeholders and platforms, since the healthcare workers might be overloaded to remember this. And then a man living with HIV had this to say, as men, we take health issues for granted and we need to be reminded. At times, if I do not have any health challenge, we do not see the need for viral load test or asking for the results. We are preoccupied with asking for money. So some of the campaign materials that we developed and deployed included this. I hope you to play this video I want to play. It's very short, so there we go.
Okay, thank you for the presentations, and thanks to Idrissa for trying to sort some of the questions already. So we'll go through a few questions in the chat box before we end. And the first question is from Justin Nyanda, and she's directing the question to Gloria. She'd like to know, how did you manage to gather people living with HIV in a WhatsApp group chat, as HIV is a private issue for a person to disclose his or her status in public? Gloria?
First of all, thank you for the question. And just to answer it, so when we came up with the idea to start a WhatsApp group, we realized that was going to be a challenge, because once you add people to a WhatsApp group, you're not able to verify if this person is actually with HIV. So then what we did is we went back to support groups. So for example, NEFAC is working in all the 47 counties, and what we did is we utilized the support groups that we have. So if you're already if people in a support group know, and most of these people in the WhatsApp group were already in pre-existing support groups, but now due to COVID, they were not able to meet. So these are the people that we added to the WhatsApp group, because you could find people DMing you on probably Twitter after a tweet chat, and then you realize that. So since you can't tell actually if this person is positive, then what happens if you add them to the WhatsApp group? Because possibly they could get the information of other people and then go out and spread it. So what we did is we decided to deal with those ones on an individual level. So if you don't belong to a support group that can actually vouch for you, then we can't add you to our WhatsApp group, just to protect the identity of those who are already in the WhatsApp group. And we realized that this is a challenge. It's limiting a lot of people who probably need these support groups. But then, since you can't actually prove that this is a person living with HIV, then you just give them information that they need on the DM. You just answer their questions on the DM where they sent you, or probably if they need a follow-up call, then you do that one. But then you can't add those who you can't confirm from, support groups or people who actually we know our champions who are already living with HIV. I hope that answers the question.
Thank you. Thank you, Gloria.
Thank you.
Dr. Daniel Kimani is directing his question to Idrissa from Sierra Leone, and he wants to know if the national viral load testing platforms are on lease or procured, and if there's backup at the center. Also, Bernard Weimi was asking about a backup. So, Idrissa.
Yeah, thank you very much. Our viral load machine is actually procured, or it was procured. And we have two viral load platforms at central level. Unfortunately, both of them were broken down. Both of them broke down. So that's the sad situation. With regards the which platform we are using for Gene Expert, I cannot say with precision. So I've just contacted my colleagues to contact NACP. Once we get that information, I will share it.
Okay, thank you.
Yeah.
Next question is from Marceline, and she's asking, she's saying very good program, but just wondering if in all these countries, viral load testing is free of charge, and whether cost can be a barrier to the lack of uptake we are seeing. So I think the question can be tackled by all the countries. So just mention whether it's free and if there's a cost to it to contribute to being a barrier. Over. So we can start with the ones who have not talked. So Tonderai. Or Gloria, just go ahead.
For Kenya, it's free, so it's free of charge. So probably the cost that probably people incur is transport to the facility just to go and your blood is drawn. So that's the only cost.
Okay, Idrissa.
Yeah, in Sierra Leone, viral load testing is free in all public health facilities.
Okay,
yeah.
And
Oui, les tests est gratuit chez nous. Mais c'est vrai que parfois, il y a des petits malins qui font payer pour les gens qui n'ont pas d'informations, mais c'est gratuit.
Okay, Tonderai?
Yeah, just like in Kenya, in Zimbabwe, viral load is also free, but some of the bottlenecks might be in terms of transport to the health facilities. That at times act as a barrier for people to access viral load testing, especially if viral load testing is not harmonized with ARVs resupply dates.
Okay, thank you. The next question comes from Dennis Lodiongo, and again is presenting this question to all of you. He'd like to know how in your campaigns you are able to pass viral load messages or reminders to clients who are unable to read or write. So again, we can go in that order. Gloria?
I'm not sure if I got the question correct, but I think, so for people who are not able to read or write, unfortunately, when you're using social media and technology, you tend a bit to miss them. So that's why we did, we're trying to get, do Zoom trainings, see if we can reach them through that. And then, once we have, I don't know, we go back to normal, to the new normal. So once we have, you've figured how to meet, then you do physical meetings for some population, because usually some population are not able to meet them virtually. You have to go to the communities and reach them with this information. So it's a bit of a challenge.
Okay, Idrissa? If he's not ready, Tonderai or Ange, how did you engage with people who cannot?
Oui,
Okay, thank you very much for the question. And
okay.
No, go. Yeah, so yeah, Ange can go ahead and then Tonderai. Sorry. Ange.
Ok, je disais que pour les personnes analphabètes ou qui n'ont pas beaucoup accès même à l'Internet, comme je l'ai dit, nous avons utilisé les pairs que nous avons pu donner les messages pour qu'ils puissent répercuter dans le groupe de support ou dans le club d'adhérence ou encore dans des clubs de discussion et que chacun puisse répercuter à ses connaissances comme une tache d'huile. Le message va de bouche à l'oreille jusqu'à atteindre le fin fond. Voilà la technique que nous avons pu utiliser.
Thanks, Ange. Tonderai.
Okay, yeah. So for us, I think that is a gap that we might need to explore how we can reach out to this subpopulation. Even in some of our feedback meetings, some recipients of care were saying, "How are you reaching out to people living with disability?" And that one, it's a gap that going forward we have to look how we can reach out to such subpopulations. Thank you.
Yeah, thanks, Tonderai. So the next question is directed at Poncho, and it's from Francis Ochen, and it's asking how you are able to estimate the reach to the different population categories that you indicated on that table.
It was, thank you, Collins, for the question, and Francis, it was a difficult thing to do considering that circulation or listenership numbers are a quarterly event in most countries. And so that is the estimation that we reached that was used, that it was according to what the radio station listenership was during those few months. So it's an estimation. It could be more or less, as we have to rely on external data that we have no control over. And these are just, it's one of the the challenges that we experience when, or rather not a challenge, I wouldn't call it a challenge, but this is something that you have to take into consideration when you are doing a hybrid model between thinking about using non-digital and digital technologies. This is what results in. And Idisra also saying that also answering a question around which machines there is being used, but it is, just to wrap up, it is the estimation of the listenership each radio station has and the numbers that are widely used in the industry.
Thank you, Pancho. So in the interest of time, I'll take just two more questions. So the first one from Estelle is directed at Ange. And the question is, what will you say is the most reliable and popular social media platform that works for DRC? Ange?
Oui, si vous voyez dans ma présentation, c'est vrai que le site web a été trop visité, mais aussi Twitter. Twitter a été trop visité, il y a eu beaucoup de gens qui ont réagi. Et après les Twitter, c'était Facebook. Bien sûr, WhatsApp, ça, nous n'avons pas pu vous présenter toutes les réactions des gens, mais WhatsApp, c'est dans des groupes déjà ciblés, déjà connus. Il y a beaucoup de gens qui ont l'information et qui peuvent interagir. Donc, d'abord le site web, Twitter, et puis bien évidemment WhatsApp et les autres. Merci.
Thank you so much. Okay, the final question to all presenters is if these campaigns impacted viral load access, coverage, or suppression. That's from Bernard and also from Neftali. So we can start with Gloria.
Hi, sorry, I was speaking with my mic on mute. So for the impact, I think we were able to communicate the information, even if it was for not so many numbers, but we were able to communicate, and then now they're aware of, you know, what VL is, when they should get it, and they're able to demand. So I guess, so one way to measure it is that people have told us that I went to the facility and, you know, I was able to ask for my VL. I was able to ask why I haven't, you know, received a test for VL. So I guess that's an impact for us. And then for coverage and access. So for access, there has been challenges, of course, with COVID. As most countries, I think we got to a point where we focused so much on COVID, and then we tended to isolate on other matters. So I think the access and such kind of things reduced a bit, but then with Twitter chats, then we are able to demand and, you know, hold these healthcare facilities to account on what needs to be done. On separation, I can't truly comment on that one, but I can always check back and get back, because one of the things is we don't actually ask what for you. I guess one of our shortcomings that we didn't ask then, are you suppressed? But then I guess into the next phase, then we can include that.
Thanks, Gloria. Okay, Ange.
Ouais, faut dire d'abord que pour nous, ou chez nous, il y a très peu de gens qui ont accès à la charge virale. Nous sommes en dessous de 50%, je pense même qu'en dessous de 40%. Et c'est déjà un problème, c'était déjà un problème avant, mais c'est vrai qu'avec la campagne, on a pu légèrement lever la barrière. Mais ce qu'il faut aussi savoir, c'est que pour les très peu qui ont accès à la charge virale, la suppression est vraiment élevée. Donc, le taux de suppression est au-delà de 85%. Donc, nous osons croire que si toutes les PVVH ont accès à la charge virale, vraiment, la suppression sera aussi la meilleure. Voilà la situation par rapport à notre pays.
Thank you. Tonderai?
Okay, thank you very much. So I think from our end, what I will say, access issues, I think, just like what Kenya said, that they were affected by the COVID-19, where at times certain services were not being offered mainly because of the COVID outbreak. However, from the feedback meeting sessions we had with the recipients of care, it looks like it improved the coverage of viral load. Some people who were not able to, or who couldn't engage service providers on viral load, were now confident to do that. This was from the qualitative information we got from the recipients of care. However, I think going forward, it needs to be triangulated with information from the health facilities, which I think was also the missing link. So maybe for second phase, we will go that way, where even if the recipients of care report something, it needs to be triangulated with the data from the health facilities. Thank you.
Thank you, Tonderai. Idrisa, are you taking the question? If not, Poncho, Adris.
We actually didn't implement, but I think this question is really very important. It will actually guide us to see when we go into full implementation, so that we'll make efforts to see if we can be able to capture this information. Thank you.
Thank you so much. So we'll go to Poncho to give comments, final comments.
Yes, final comments. It's just on regards to the last question, you know, I don't know if Neftali was there at the last presentation that I did last year, but it is quite hard and challenging for the campaign to translate directly into increase in usage of viral load testing, coverage, or even in viral suppression. And this is because that in order to get that kind of change, it's more multifaceted than just a digital campaign or a campaign like this. Also considering how short one of, like the lessons we said that we would have needed to implement for longer. So even though that is our ultimate goal, we need so much more resources around not just the campaign itself, what the communications campaign enable or allow for is they create an enabling environment that allows for the possibility of viral suppression, increase in viral load testing through the empowering of people living with HIV, empowering them with knowledge, and also with the language to advocate or demand viral load testing in their facilities. And so I would say if we had a 10-step program with these campaigns, we get to step 3, and we still need more advocacy, door-to-door, lobbying of ministries of health in order for us to directly see an impact. And this is why it's so important to also note that after everyone has presented that, we are actually currently in the second phase of implementation. So we are taking all the lessons that we've learned from the first implementation phase between October and January this year. We've had a refresher workshop where we've reviewed the campaigns of each country team and reviewed the plans as well to create more effective campaigns. And by this, we mean that, as we looked at each country team, for instance, in Zimbabwe, certain platforms work better with certain audiences. So instead of casting our net wide, as we did in the first implementation phase, what we're now doing in this second implementation phase that started at the beginning of this month is that we are doing more focused and more pointed communications campaign, still based on the very same things that we discussed, but now what we're trying to do is really shift the perceptions within the communities of people living with HIV. And we have revised and tailored the communication plans with more targeted and selected platforms and audiences so that we are able to observe a smaller group with more resources and energy being diverted or concentrated into these smaller groups with these smaller platforms in order for us to see what the perception change looks like and whether or not we are able to measure the perception change. And that will inform us what more is needed to get to what I would call our golden goose in this case, which is where we do have recipients of care asking and demanding for viral load testing within their facilities. And we see the reaction or the services being provided by ministries of health. And so it's yes, we could see it, but we cannot directly say we've seen it now. And in the next 6 months, we're implementing between June and November this year. And the campaign will be longer, it will run for longer, it will run with more focus and with more detail in each specific country. And we are hoping that we will be able to answer this question, hopefully when we have another opportunity to present at a LabCoP meeting, let's hope sometime early next year.
Thank you, Pancho. So well summarized, and I think at this point we want to stop. Thank you, ITPC, for putting up this together, and also the country teams for their hard work. We look forward to collaborating with you on the phase 2 of the project. Thank you so much, and bye.